sorted and then we will get going. So today we will be discussing important questions from the endocrinology for the prof exam. I will try to cover at least 50% of the important questions from endocrine so that the remaining you will cover from the Farre notes. And tomorrow we will complete the important questions from rheumatology as well. If you do the questions that we have discussed so far in the Farre, including today and tomorrow session, you should be able to cover more than 60% of questions that are going to come in your prof exam. And if you complete the remaining questions from Farre, then you will be able to deal with most of the questions that can be asked in any of the final prof exams. Okay, so let us start with the first question. Of course, when it comes to endocrinology, in fact, in the whole medicine textbook, endocrinology makes the maximum of the overall content. And also, if you see the NEET PG questions and all, endocrinology has started taking a lot of chunk of MCQs. In the past, we were all fascinated by cardio neuro, but truth is endocrine diseases are way more common in clinical practice because almost every third person coming to OPD past 40 years of age is diabetic. So first question we are addressing is on diabetes. The question may go like this: discuss the diagnostic criteria, types, complications, and management. So as an assessor or a teacher, what are the factors that I am looking at? Okay, so the first factor that I'm particularly objectively looking at is whether you mention the diagnostic criteria right or wrong, because numbers matter when it comes to diagnosis. Then just listing of complications or basic classification, a proper description of subtypes of diabetes. And then when it comes to management, at least mentioning the goals or targets specifically, number-wise correctly. If that is done, I'm going to give more than 7 out of 10 marks or more than 15 out of 20 marks, right? So let's begin by the diagnostic criteria for diabetes mellitus. So when we look at the diagnostic criteria for diabetes mellitus, we are following the American Diabetes Association criteria. American Diabetes Association criteria. So ADA criteria says a person is said to be diabetic if the first criteria is fasting blood glucose is more than or equal to 126 milligrams per deciliter. And here I want you to specifically mention in your paper that when we are saying fasting, it refers to minimum of 8 hours of no calorie intake, right? Fasting means 8 hours of no calorie intake. That means there's no absolute fast. You can drink water, but no food item that contains calories. So fasting is equal to 8 hours of no calorie intake, That is how we are defining what is fasting. Okay. So if anybody's values are more than or equal to 126 milligrams per deciliter, it is diabetes. Okay. Second, the postprandial. The postprandial means after meal blood glucose levels of more than or equal to 200 milligrams per deciliter. That is also diabetes. But again, postprandial, when we say, we are not referring to anyone taking random amount of carbohydrates in their meal and then checking the sugar. See, of course, if I take some nice 4 gulab jamuns and then check my sugar, and the next time I take one small idli and check my sugar, they're not going to be same. So we have to standardize how much of glucose they take in the food and then check the postprandial sugar. So how do I standardize? Here, postprandial is equal to after taking 75 grams of anhydrous glucose. So basically, we are not asking them to have a breakfast, come and check your blood glucose. We are giving them 75 grams of anhydrous glucose dissolved in water. So they drink the glucose and then we're checking the sugar. Not like have some puri, samosa, dosa, and then we will check. Every food item will have different impact on the food in blood glucose levels, right? The third one is HbA1c. So if we have good evening, Alfred Rashid. Good evening, Santhosh. Third one is going to be HbA1c of more than or equal to 6.5. The glycated hemoglobin of more than or equal to 6.5%. The fourth is particularly important. Let us say I got random blood glucose checked. In fact, today I got my random blood glucose level checked. If you can see, I don't know how, if you can see. So I will get my report in some time. can I use that report to diagnose me as having diabetes? The answer is yes and a no. Why no? Because random blood glucose level, of course, depends on how much calories I have taken, what was the glycemic load or glucose in my food, and when did I take it last. All of that will have an influence on my sugar, so it's not very reliable. But if I have signs and symptoms of hyperglycemia, or if I'm in a hyperglycemic crisis, what are the hyperglycemic crisis? Diabetic ketoacidosis or hyperosmolar non-ketotic state. In such cases, a random blood glucose level also can be taken as diagnostic. So if you have a random blood glucose level of more than or equal to 200 milligrams per deciliter plus, this plus is very important. Either you have signs and symptoms of hyperglycemia, or you have hyperglycemic crisis. You have hyperglycemic crisis. So what are the signs and symptoms of hyperglycemia? Hyperglycemic crisis means it could be diabetic ketoacidosis or hyperosmolar hyperglycemic state. So when you talk about the signs and symptoms of hyperglycemia, you know the classical 3 P's. What are those? Polyuria, polydipsia, polyphagia. Increased urination, increased thirst, and increased hunger. Polyphagia. So these are the 3 P's. Plus now we consider one more important component of hyperglycemic symptoms, that is weight loss. So when you're developing diabetes, when you have insulin resistance, you will gain weight. But upon development of florid diabetes, many people lose weight. So if weight loss is there, that can also be considered as a sign or symptom of diabetes. So if I take a random blood glucose level in a person who does not have hyperglycemic symptoms, who does not have DKA or HHS symptoms, then can I diagnose it as diabetes? No. In that case, you can have a suspicion. Like if my report comes and it says I am having more than 200, I don't have polyuria, polyphagia, polydipsia, I don't have weight loss, I don't have any signs and symptoms of DKA or HHS. So if my sugar value comes more than 200 random, then tomorrow I have to go ahead with these tests. And if these values fit into the diagnostic criteria, then I will diagnose it as diabetes. If not, then I am not diabetic yet. Okay. So this is the diagnostic criteria, which is based on American Diabetes Association. Now that we know the diagnostic criteria, let us also talk about the types of diabetes. Okay, there are more elaborate classification, but in this class, I will stick to the simple classification that you can replicate in your exam. So we know that there are two major types of diabetes. The first one is type 1 diabetes mellitus, the other one is type 2. And there are some other relatively less common types, which we will just list as others. We can have a more detailed classification of other subtypes also, but for simplicity, we will keep them as others. So the first one that we're talking about is type 1 diabetes mellitus. And then we have type 2 diabetes mellitus. And then we have others. Okay. Now starting with the type 1 diabetes mellitus. So type 1 diabetes mellitus is due to insulin deficiency. So in type 1 diabetes mellitus, we don't have sufficient insulin production, right? And it is usually because of the destruction of pancreatic beta cells, which are producing insulin. But in type 2, the insulin production is indeed normal. In fact, in the initial stages, it may be high. Then why are we developing diabetes? Pancreas is producing insulin, but the insulin fails to work at the level of insulin receptors. So basically what happens is, okay, I have this pancreas which produces insulin. It senses the blood glucose level, and whenever blood glucose level increases, that will stimulate the insulin production. The insulin will go to the cells, right? On the cells, we have what we call as insulin receptors. On the cells, we have insulin receptors. So this insulin will go and bind to the insulin receptors and increase the uptake of glucose into the cells. And as the glucose goes into the cells, the blood glucose level comes down. Now this glucose, cells will either use it for its metabolic purpose, or if it is adipocyte, they will convert it to fat and store. But at least the blood glucose level comes down with insulin. Now in type 1, these pancreatic beta cells which are supposed to produce insulin, they are destroyed, so we don't have insulin production. In type 2, the problem is at the level of insulin receptors, which are becoming dysfunctional, or in simple words, we have started developing resistance to insulin. So insulin fails to stimulate the insulin receptor, and that's why glucose cannot enter into the cell. So we are unable to lower the blood glucose level. What is the main mechanism in that case? Insulin resistance or receptor defect. So in type 2, there is insulin resistance. There is insulin resistance. And if there is insulin resistance, to counter that, of course, pancreatic beta cells will try to increase the insulin production. So type 2 in initial stages is associated with hyperinsulinemia. But as these cells keep working more and more, these pancreatic beta cells start losing life. They start dying because they are being hyperstimulated to produce more and more insulin. And everything has a limit, right? Like if you keep running beyond normal running activities that a person is expected to do, like, okay, if you're running 20-30 minutes a day, I can say it's fair, it's normal. But if you're running 4-5 hours a day, then because of overuse, you will have knee joint problems, right? You will develop osteoarthritis. So similarly, because of prolonged hyperstimulation, the pancreatic beta cells start losing their life. And as the pancreatic beta cells eventually decrease in number, insulin production also comes down. But in type 2, to start with, we have insulin resistance, and to counter that, we have increased insulin production. There is no insulin deficiency in the initial stages. Later stages, insulin deficiency can happen. So here you can mention that initially there is hyperinsulinemia. Insulinemia to overcome insulin resistance. To overcome insulin resistance. Ulfat Rashes, right. So we will discuss more about the monitoring of the glycemic control also, because once we have diagnosed diabetes, we also need to know whether it is controlled or not with our medications and lifestyle interventions. So we'll discuss about HbA1c there. To overcome insulin resistance, there is initially hyperinsulinemia. Eventually, there will be decrease in insulin production. Okay. Under other categories, I want you to list something called as LADA, latent autoimmune diabetes of adults, then maturity onset diabetes of young, and gestational diabetes mellitus. Gestational diabetes mellitus. Apart from that, there are neonatal diabetes mellitus and all, which is relevant to pediatrics. In a pediatric question, you can talk more about it. Okay. Now this type 1 diabetes mellitus, there is insulin deficiency, which is due to pancreatic beta cell destruction. But then why are the pancreatic beta cells getting destroyed? So in majority of the cases, we get to know the cause. In some patients, we don't get to know the cause. In patients where we get to know the cause, the destruction is usually because of our own immune system causing the damage to the pancreatic beta cells. So in other words, it is autoimmune disorders. So if it is autoimmune, then that type of type 1 diabetes mellitus will be called as type 1A. And if we don't find any cause, then it will be called as type 1B. So type 1A is autoimmune. Type 1A is autoimmune. Type 1B, we don't know the cause, so we'll call it as idiopathic. So more than 90% of the cases of type 1 diabetes mellitus where there is insulin deficiency, we will have antibodies detectable. But in around 5 to 10%, we may not detect antibodies, so they become type 1B. Easy to remember it is because type 1A is autoimmune. So A for A. B is, of course, idiopathic. Okay, so now in the type 1A, what antibodies are encountered? So antibodies that we get in type 1A, your teachers want you to write it because when I have to diagnose type 1, most common is type 1A itself. So I also need to rely on antibodies also for the diagnosis. So antibodies that we encounter in type 1, first one is anti-glutamic acid 65, anti-GAD 65 antibodies. Then we have anti-insulin
autoantibodies or anti-IA2 antibodies, and then we have anti-islet cell antibodies, and we also have anti-ZNT8 antibodies, anti-ZNT8 antibodies. So these are the antibodies that we encounter in type 1A. Okay, now one question that your teachers might ask during the Viva asking. See, if I have these antibodies, then I know probably I'm dealing with type 1A, but if these antibodies are negative, it could be type 2 or it could be type 1B also, right? So how do I differentiate exactly between the type 1 and type 2? Antibodies may not be perfectly reliable, or at least I can say that antibodies negative does not rule out type 1 diabetes. So then how do I differentiate? How do I differentiate? Yes, there are history pointers. Usually type 2 insulin resistance manifests after 3 decades of life, means unlikely to present in first 10 years of life, first 20 years of life, maybe after 25, 30, 35 years. Usual age of presentation in the past used to be 40 plus, but with the lifestyle that we are living now, it is coming down. We have started diagnosing even 27, 28-year-old with type 2 diabetes mellitus. Type 1 usual presentation is in childhood to early adulthood, usually less than 20 to 25 years of age. Majority of the type 1 present in the childhood itself. Yeah, so that factor is there. But still, if I get some 25-year-old, I will always have the confusion whether it is type 1 or type 2, because type 2 age of presentation has come down. Type 1 can present up to that age. So what investigation helps us to differentiate? Well, remember, whenever we look at the insulin, right? Insulin is not produced in a fully final form, which is insulin. Insulin is actually produced as a proinsulin. So pancreatic beta cells produce a peptide called as proinsulin. This proinsulin gets broken down in the body to produce two substances. One of them is insulin, the other one is C-Peptide. C-Peptide. Okay, so now if I have type 1 diabetes mellitus where there is decreased insulin production, beta cells are destroyed, then this proinsulin production will be less. That's why insulin production will be less. In that case, C-peptide levels will also be less. So in type 1 diabetes mellitus, if I check the C-peptide levels, it will be low because overall pre and proinsulin production is less. So insulin and C-peptide production will be proportionately less. But if I look at type 2 diabetes mellitus, see in type 1, regardless of whether it is autoimmune or idiopathic, C-peptide will be low. But if I look at type 2, what will happen to the C-peptide? In type 2, insulin resistance is there. So to counter that, I have to increase the insulin production. I cannot increase insulin production alone. I have to increase the production of proinsulin. So if I produce more proinsulin, I will also have high C-peptide. So later stages of type 2 diabetes mellitus, the C-peptide may be low, but in initial stages it will be high because you have insulin resistance. So you can mention it here that type 1 will have low C-peptide levels and type 2 will have increased C-peptide levels, at least in initial stages. So if your teachers ask how do you differentiate if the age and other factors are in the gray zone, you can say, sir, I can use the C-peptide levels. Okay, so that's about the basic classification. So usually MODY presents after 25 years of age. Type 1 most commonly presents before 25 years of age. So that's why in the name of the MODY itself we say maturity onset diabetes of young. So it is onset after maturity in a relatively young individual, not in the pediatric age group. So if you get someone in pediatric age group, it's most likely going to be type 1, not going to be MODY. The second thing is in MODY, it's a autosomal dominant condition. So you will have a strong family history. Type 1, you may not get a strong family history. So in case of MODY, you will have at least 2 or 3 generations of family members like, okay, father, grandfather also had diabetes, now this fellow also has diabetes. It's a very much important point for the diagnosis of MODY. You need to have at least 3 generations of involvement, because it is autosomal dominant inheritance with high penetrance. On the other hand, in type 1, it is usually like sporadic cases. Neither father, mother have, because it's autoimmune disease is an acquired condition. So it's often sporadic. So you may not get the strong family history. So that is another point that we can use for differentiation. Okay. So now that we know the different types of diabetes mellitus, let's get into the complications of diabetes mellitus. So what are the complications this diabetes will cause? So when we talk about complications, we will classify them into acute and chronic diabetes mellitus complications. We'll classify them into acute and chronic. So what are the acute complications that diabetes mellitus can lead to? So the first, in fact, the most common acute complication of diabetes mellitus is not because of hyperglycemia, rather treatment of diabetes leading to hypoglycemia. So some teachers might, Diana, what point you want me to explain again? See, MODY, as the name says, is maturity onset. So it is not, the onset of the disease is not in the pediatric age group. Okay, so it is when you are relatively younger, in your second decade or something, less likely to present in the pediatric age group. That's why we call it as maturity onset. But of course, not at the age group where usual type 2 present, that is 40 years or higher. So that's why it is called as maturity onset diabetes of young age, but post maturity, not in the pediatric age group. Type 1 can present in the pediatric age group. Then type 1 generally does not have a strong family history, though genetic abnormalities contribute to the autoimmune process, like certain HLA variants. There is no pattern of inheritance, so that's why you don't get the strong family history. But MODY is an autosomal dominant disorder, means you can't acquire maturity onset diabetes in young. You have to get it genetically. And being autosomal dominant, if I have MODY, my father should also have. If my father has MODY, one of his parents should also have, right? Either my parents should have, if my parents, one of them have, their parents, one of them should have, because it is an autosomal dominant condition. So that's why for diagnosis of MODY, we need to have this family history of having diabetes. My father, grandfather both had diabetes, I also have diabetes, then it could be MODY. We don't generally encounter such strong family history, means you can have, but not such a very patterned autosomal dominance pattern of inheritance in case of type 1 diabetes mellitus. Okay, so this diabetes mellitus, Diana, is classified into 2 major types, that is type 1 and type 2. We have relatively less common types like latent autoimmune diabetes of adults, maturity onset diabetes in young, and gestational diabetes mellitus, neonatal diabetes, drug-induced diabetes, or steroid-induced diabetes. Those are all subtypes. Most common are type 1 and type 2. In type 1, there is decreased insulin production because pancreatic beta cells are destroyed. The destruction can happen because of autoimmune process, or in some cases, we don't know the cause. Majority of the cases, it is autoimmune destruction of the pancreatic beta cells. So our own body produces these antibodies, anti-GAD65, IA2, islet cell antibodies, ZNT8 antibodies. These antibodies cause the destruction of pancreatic beta cells. So once the beta cells are destroyed, they are not able to produce insulin. And how do I detect that beta cells are not able to produce insulin? When beta cells produce insulin, they produce it in a form called as proinsulin. The proinsulin is a large peptide, means multiple amino acids. Body cleaves it to make one molecule of insulin and one molecule of C-Peptide. So they are produced in equimolar concentration. So whenever insulin production is down, C-Peptide production will also be down, because like they are produced together in as one peptide and then broken down into 2. So I can use the C-Peptide level as a marker for diagnosis of type 1. In type 1, C-Peptide levels will be low. We can also use C-Peptide for the diagnosis of hyperinsulinemia. If there is an insulin producing tumor, what you call as insulinoma, C-Peptide levels will be very high, because high amount of insulin production means high amount of proinsulin production. That means also high amount of C-Peptide. So in type 2, insulin production is normal, but there is resistance at the level of insulin receptors. So insulin production is normal, insulin goes to the receptors but fails to do its job of lowering the blood glucose level. So to counter that, body will produce more insulin. Every time there is a resistance to some hormone, there will be increased production of that hormone. So to overcome that resistance, and because there is increased insulin production in these patients, what we call as hyperinsulinemia, C-peptide levels will also be high. And in fact, this hyperinsulinemia leads to some of the clinical manifestations that we get in diabetes. What are those? We can get something called as acanthosis nigricans. What is this acanthosis nigricans? That is a sign of, we call it as a sign of insulin resistance, which is nothing but a sign of hyperinsulinemia. We can have acanthosis nigricans and skin tags. Okay, some of you might have heard a term called as insulin-like growth factor. Why is it called as insulin-like growth factor, which is produced by the liver in response to growth hormone? Called as insulin-like growth factor. So what is the similarity? So remember that IGF-1 and insulin both are growth factors. They're not just like, insulin is not just only to, its job is not only to decrease the glucose. It also stimulates cells to grow more, replicate more. So this, right, you might know that diabetes is a risk factor for cancers. Why? Especially type 2. It's because when you have high amount of insulin in type 2 to overcome the resistance, that insulin is stimulating cell replication and cell growth. So when your epithelial cells, keratinocytes on your skin get hyper stimulated, they replicate more, produce more keratin, and that's how we end up with development of acanthosis nigricans and skin tags. Similarly, this hyperinsulinemia can also push you towards cancer. So it's like, it's a well-known risk factor. So any patient who has acanthosis nigricans or skin tags, you can say that he is already going through hyperinsulinemia. Even if his blood glucose level is normal, he is taking steps towards becoming type 2 diabetes. So if he does not correct his insulin resistance, then he will end up with type 2 diabetes mellitus. Okay. So in terms of complications now, we have acute. One of them is hypoglycemia, which is not directly caused by diabetes, but when we have diabetes, we treat. For treatment, we give drugs which lower the blood glucose level, and any increased dosage or decreased calorie intake will result in hypoglycemia. This is in fact the most common complication. After that, we have diabetic ketoacidosis, and we have hyperglycemic hyperosmolar state. Hyperosmolar state. So these are acute complications. Then we also have certain chronic complications, and the chronic complications are further classified into microvascular and macrovascular. So majority of these chronic complications are due to accumulation of what we call as advanced glycation end product. So what are these advanced glycation end product? And also formation of sugar alcohol. So if you want, you can just note it down. It is due to advanced glycation end products, AGEs, and sorbitol, which is nothing but a sugar alcohol. When we have excess sugar, it may get fermented to form sugar alcohols like sorbitol and various other sugar alcohols also. So what are these advanced glycation end products? Basically, excess sugar molecules start attaching to proteins. Your glycated hemoglobin is one of them. So similarly, there are various proteins in the body. They may get glycated, like protein bound by the sugar molecule. But once the sugar molecule binds it, it alters the structural and functional nature of that protein. And in whichever tissues those proteins were doing some functional job, they get altered. So that organ starts becoming dysfunctional, and we can have organ dysfunction. So these chronic complications, we will classify them as microvascular, where small blood vessels are affected, and macrovascular, where large blood vessels are affected. So what are the macrovascular complications? The first macrovascular complication, which is in fact the most common cause for death in patients with diabetes, is coronary artery disease. Coronary artery disease. So you can simply write it as CAD, or you can say coronary artery disease, or you can also write it as ischemic heart disease. The second one is cerebrovascular accident, or CVA, or you can write it as stroke. Cerebrovascular accident, or CVA, or you can write it as stroke. The third one, peripheral vascular disease. Guru Mantesh, soon. Once the Farre is over, we will be getting back to Reed Harrison. Peripheral vascular disease or PVD. So you can simply remember these as CAD, CVD, PVD. Coronary vascular disease, cerebrovascular disease, and peripheral vascular disease. So these are the macrovascular complications where larger blood vessels get affected by diabetes. Mainly what happens is diabetes leads to accelerated atherogenesis, injury to the endothelium, formation of a clotting blood vessel. And if it is a blood vessel going to brain, I end up with stroke. If it is a blood vessel going to heart, I end up with ischemic heart disease or MI. And if it is a blood vessel going to any of the peripheral body parts, that part will become ischemic, right? So we can develop gangrene. So these are our macrovascular complications. The microvascular complications are easy to remember. All you have to remember is pathy, neuropathy, nephropathy, retinopathy. All these pathies are microvascular complications. Diabetic neuropathy, then diabetic retinopathy, and diabetic nephropathy. So you should know that the diabetic neuropathy that we are talking about here, the most common type of neuropathy means a disease involving peripheral nerves, right? The most common type is distal sensory motor polyneuropathy. How does that present? It will presenting as glove and stocking distribution of sensory loss. Teachers are very much fond of this word, glove and stocking distribution, because like if you remember from the neuro discussion, the peripheral neuropathies, especially the polyneuropathies, where multiple nerves simultaneously get affected, distal most parts of the body get affected first, means hands and feet. That is where we wear the glove and stocking. So that's why if you see diabetic patients, they are often complaining of pins and needle sensation and burning sensation in the feet and then eventually in the hand. Okay. Diabetic retinopathy, Sudha ma'am will address in the ophthalmology. Diabetic nephropathy, we already know a few points about it. The first point is it is the most common cause for CKD in India and the world. So we have discussed about it in CKD. Hypertensive nephropathy is second most common cause. So all these advanced glycation end products, they cause damage to the kidney as well, resulting in advanced or end stage renal disease requiring dialysis. So this is the most common cause for CKD. Okay, so these are all complications that we are expecting in diabetes. And if these are the complications, then we already know that these complications are better prevented than treated. Because once there is end stage renal disease, you have to go for transplantation or dialysis. Once there is severe retinopathy, it's very difficult to treat. It can lead to permanent vision loss. This diabetic neuropathy, once the nerves are permanently damaged, it's not possible to reverse them. So best thing is prevent them. And to prevent them, the best thing is control the diabetes. So if you do not have a significant elevated blood glucose level, these complications are reasonably prevented. So that's why recognizing and treating the diabetes is important. So when it comes to the management of diabetes mellitus, first let us address the type 1, which is pretty simple. Type 2 is where we have complications. I know for a patient with type 1 diabetes, life is quite a hell. But for a doctor, it is, at least for the exam sake, it is simple. Why? What is the problem in type 1? We have insulin deficiency. Pancreatic beta cells are gone. So can I give some drug to produce more insulin? Not possible, because pancreatic beta cells are not there. The factory is not there. So I can't stimulate anything. If I had the factory, I can tell the factory, give me more output of insulin. But I don't have the factory. Factory is destroyed. Then what is the only way to treat? Insulin from outside. So type 1 diabetes mellitus is always treated with insulin diet and lifestyle therapy. So these patients are, because most of them are detected in the pediatric age group itself or early life, we need to train them to take insulin. At the same time, also we need to train them to calculate the glucose load or carbohydrate load in the food, and according to that they have to adjust the insulin. See, at that age, growing age, we can't rigidly restrict them what kind of food they can eat. Often there will be cravings. The kids might end up like, see, all other friends are eating a small candy, and I also want to take a bite. Now I'm a child. How long I can suppress my urges, right? It's very difficult. So that's why it's better to train the patient as well as the family members to calculate the glycemic load of their food. And if they are trained, they can take 1 or 2 units of insulin more to counter that excess glycemic load that is coming during that particular period of time. And that way they can get a better control of the glucose, right? So in the exam, at least we are writing that insulin is the treatment of choice for the type 1. There is no other way we can treat. Yes, we can use alpha glucosidase inhibitors, which decrease the absorption of glucose, but their efficacy is negligible. Like, I can't say that, okay, I can manage with alpha glucosidase inhibitors. The only way I can manage is insulin. I may get a little bit help from alpha glucosidase inhibitors. No need to write in the exam. It is that insignificant. But then when it comes to type 2, there are so many ways of treating the type 2 diabetes mellitus. And the first thing that you need to know is that in type 2 diabetes mellitus, we have insulin resistance. And in the early stages, a reasonable improvement in insulin resistance can be achieved. How do I achieve that? By lifestyle and diet. Lifestyle modification is the cornerstone of treatment of diabetes patients. So what lifestyle modifications I would recommend? So now studies after studies have shown that losing excess fat mass. So when I say weight loss, I'm primarily referring to fat loss, not the muscle mass loss, because muscle is the largest metabolic organ in the body. It is using the maximum amount of glucose apart from your brain. So if I lose muscle mass, I'm losing a tissue that is able to use the glucose. So my blood glucose level will be high. I will have insulin resistance. My diabetes will worsen. But if I retain muscle and lose fat, my insulin resistance comes down. So the goal is fat loss. Technically, you can write it as weight loss. Weight loss improves insulin sensitivity, and in early stages, especially pre-diabetes, it can reverse. Like, you don't have to continue, the pathophysiology need not continue. If you maintain that lifestyle with a low fat mass, you may remain diabetes free throughout your life. That also means that not every pre-diabetic will progress to diabetes. If they take control of their lifestyle, they can get better. Okay. Then apart from this, I need to retain the muscle mass. So I would strongly recommend these patients to follow resistance training, because without stimulus to the muscle, they can't retain the muscle mass. Okay. Now coming to the diet, we generally recommend low GI, high fiber diet. What do I mean by glycemic index? How quickly the glucose can be absorbed from a food, right? So if the high GI is there, glycemic index is high, that means the glucose is absorbed from the food quite rapidly, quickly. Like, for example, if I directly take glucose, or if I take simple starches like potatoes just boiled, or high sugary items, glucose is absorbed quickly. But if I take, let us say, to give you an example, vegetables have relatively low GI. They may have carbohydrate, but its absorption is very slow. In fact, the presence of fiber itself slows down the absorption. So low GI, high fiber diet is recommended. How many calories? That is based on the patient's current body weight, whether he is an ideal body weight or not. All of those factors will be taken into account. After that, if diet and lifestyle fail to control blood glucose, then we go for pharmacotherapy. So pharmacotherapy need not always be the first line of management. Then we go for pharmacotherapy. So when it comes to the pharmacotherapy of diabetes, what all drugs we have, what all classes of drugs we have. So first we have biguanides, then we have sulfonylureas. If it is not specifically asking you to write the pros and cons of individual class of drugs, then don't waste your time, just list the medications and then talk about the diabetes control goals. But if they're specifically asking, at least be able to write 1 or 2 common side effects of each class of drugs. So biguanides, sulfonylureas, then we have DPP4 inhibitors, dipeptidyl peptidase 4 inhibitors. Then we have alpha glucosidase inhibitors. Then we have relatively new SGLT2 inhibitors and GLP-1 analogs. Nowadays these drugs are quite popular, all of you know about them. And then finally we have insulins. Okay, so an example for a biguanide is going to be metformin. Now how does metformin work? It works by AMPK pathway. By acting through or activating the AMPK pathway, it decreases insulin resistance. And what are the side effects that we expect? There are 2 major side effects. The first one, long-term use of metformin is associated with B12 deficiency. In a country like India, it's a problem because as such, majority of this country's population is vegetarian. Their diet does not have sufficient B12, and you add, in fact, this not having like vegetarian diet itself is a risk factor for developing diabetes, because especially when you look at South India, our diet is loaded with carbs. We don't have sufficient protein. We don't have even sufficient fiber, because like idli, dosa, all of these are carbs, pure carbs, not much fiber. Along with that, chutney, coconut, medium chain triglycerides, not much of fiber again. So we lack fiber, have high amount of high GI carbohydrates. So that increases the risk of developing insulin resistance, makes me develop diabetes. And the same diet also lacks B12. So because of that, I'm already prone to B12 deficiency, and then you start metformin, I become even more prone. So that's why, especially if you're giving metformin to a pure vegetarian, maybe it's worthwhile considering evaluating their B12 status, and if required, adding a supplementation. Second, metformin increases the risk of developing lactic acidosis, especially in patients who have renal insufficiency. Already GFR is low, the chance of developing lactic acidosis is high, right? So these are the 2 major side effects. So that's why whenever GFR goes below 30, metformin is contraindicated. We don't use metformin in those patients. And when the GFR drops below 60, we have to decrease the dose of metformin. We can't give the full dose. Okay. The next class is sulfonylureas. The examples we can quote for sulfonylureas: glimepiride, the most commonly used sulfonylurea in India, glimepiride. Then gliclazide, glibenclamide. So we can go on listing them. So these are sulfonylureas. How do they work? These work by increasing the insulin secretion. So they are called as insulin secretagogues. Insulin secretagogues means they stimulate the beta cells to produce more insulin. So what side effects I would expect in these cases, the sulfonylureas? What side effects sulfonylureas can lead to? The major side effect that's almost seen in all patients who are using sulfonylureas for 3-4 years or higher is gaining weight, because this stimulates the beta cells to produce more insulin, and that excess insulin that what we are producing will help you bring down your blood glucose level by trying to overcome the insulin resistance. But how? That extra glucose in the blood is put into the cells, and cells are not able to burn it because they don't need so much extra. So they store all of that in form of fat. So you gain fat, you gain weight. So one of the common side effects of sulfonylureas is weight gain. We don't have that problem when it comes to metformin. In some studies, it is also shown that metformin causes weight loss. The second side effect is when insulin is high and if I don't take food, I can get into hypoglycemia. Metformin doesn't cause hypoglycemia because it is not increasing insulin production. But this one can cause hypoglycemia, which is a very common and a major side effect of sulfonylureas. Given these factors that they cause weight gain and hypoglycemia very frequently, modern day doctors don't prefer to prescribe sulfonylureas. But still, yeah, if the patient cannot afford better drugs, we don't have a choice. We do prescribe with a lot of effort to educate them about the possibilities of hypoglycemia, how they should be prepared to face hypoglycemia, and when they encounter symptoms, how do they manage themselves. So that is very much important when you are giving sulfonylureas. If you just prescribe like, okay, take glimepiride and go, they may get into hypoglycemia. They may not be even aware what is happening with them. They may not reach the right place for the care, and it can be even life-threatening, right? So please remember that. In fact, two classes of drugs are known to cause hypoglycemia. The other classes are not known to cause hypoglycemia. What are those? Sulfonylureas and insulin. Metformin doesn't cause hypoglycemia alone. DP4 inhibitors do not cause hypoglycemia alone. Alpha glucosidase inhibitors do not cause hypoglycemia alone. SGLT2 inhibitors, GLP-1 analogs, these do not cause hypoglycemia alone. Okay. So DPP4 inhibitors, examples we can quote is sitagliptin, vildagliptin, linagliptin. Linagliptin is particularly important from MCQ perspective. Linagliptin is metabolized by liver, so you can use it in patients with the renal dysfunction. Yes, absolutely right. See, the sulfonylureas, because they are facilitating a lipogenesis by causing increased insulin production, they are facilitating lipogenesis. So they also accelerate the rate of atherosclerosis. So that pushes you more towards developing atherosclerotic complications, including the cardiovascular mortality. See, given a choice, if my patient can afford, I would never prescribe them a sulfonylurea because we have much better drugs available today. In the past, we didn't have. So after metformin, sulfonylureas were by default the next best choice. But yeah, we have DP4 inhibitors now, which are much better tolerated, do not cause hypoglycemia, do not increase the rate of atherosclerosis. Alpha glucosidase inhibitors, example we can quote is, can anybody name an example for alpha glucosidase inhibitor? Yes, acarbose. Acarbose is a alpha glucosidase inhibitor. So this alpha glucosidase helps in breaking down the carbohydrates in your GIT, and if I block that, I may not be able to absorb glucose. So it reduces the dietary absorption of glucose. What side effect it can lead to? If I'm not absorbing glucose, that glucose gets fermented by intestinal bacteria into sugar alcohols, and those sugar alcohols will create dyspepsia, gurgling sounds in the abdomen, bloating, and other GI symptoms, even diarrhea sometimes. Okay. Next most important class of drugs, which is now one of the standard drug for diabetes management apart from GLP-1 analogs, is SGLT2 inhibitors. What do? Our blood repeatedly goes to the kidney for filtration, and during that process, glucose also gets filtered out by the kidney, and that glucose gets reabsorbed by SGLT2, and we eliminate the remaining urea, creatinine in urine. But if I block this SGLT2, then I will allow the filtration of glucose, but I will not reabsorb it. I will excrete that glucose in urine. So this is how I can lose glucose from the body, and because I'm losing glucose from the body, blood glucose level will come down. Okay, so examples we can quote for this class of drugs: all your glipizins like empagliflozin, dapagliflozin. Okay, now it's there in the name. The mechanism is inhibition of the SGLT2. Their advantages, they have an added advantage. What are the advantages? They cause weight loss. which in most of the type 2 diabetes mellitus patients is an advantage. Why is that an advantage? Because majority of them have insulin resistance, they are already overweight or obese. How are they causing weight loss? Because they inhibit glucose absorption in the kidney. I lose anywhere between 50 to 70 gram of glucose per day in my urine. And that 50 to 70 gram of glucose is equal to almost 200 to 280 calories. Literally equivalent to 1 hour of aerobic activity like swimming, cycling, or running. So that much of calories or glucose from the body they are losing passively. So because of that, they're losing weight. This weight loss indirectly benefits insulin resistance. So that is an added advantage. Then this drug is also known to decrease the blood pressure. Because if I'm losing glucose in urine, glucose is an osmotically active substance. So it will also make me lose some amount of water along with that. So it has, you can say, a mild diuretic-like action or aquaretic action, making you lose water. That brings down the BP. So you know diuretics can bring down the BP. So this has a mild action like that, so it can bring down the BP. And overall studies have shown that this class of drugs decrease cardiovascular mortality. Decrease cardiovascular mortality. I've already told you the most common cause of death in diabetic patients is going to be coronary artery disease. And this class of drugs, if they are prescribed, they decrease the risk of death. And it's not just because of the glucose control. The benefit is over and above that. Means glucose control will reduce the death risk by heart attack to some extent. But whatever that is, in addition to that, if it is achieved with SGLT2 inhibitors, you get extra benefit. You get more reduction in the cardiovascular mortality. And just like any other class of drugs, these will also have side effects. So what side effects we are expecting in these patients? Because I'm losing a lot of glucose in urine, I become prone to develop urinary tract infections, particularly females, because you know the female anatomy favors UTIs. So urinary tract infection, bacterial as well as fungal, there is increased risk. And it is the most common side effect that we encounter with SGLT2 inhibitors. Weight loss is not considered as a side effect, rather considered as a benefit. Okay. Apart from that, it causes something called as euglycemic ketosis. Okay, we'll try to understand what is this. And meanwhile, you'll also understand a little bit about diabetic ketoacidosis. So normally what happens is, if I have very high amount of blood glucose, what will happen to this blood glucose? High amount of blood glucose will lead to increased urinary glucose. Because there is high amount of glucose in the blood, some of it is getting filtered in the urine. So in the urine also glucose is increasing. And if I have increased urinary glucose, as this glucose goes away, because glucose is osmotically active, it is not going alone, it is taking water molecules with it. So it leads to polyuria. I have increased urine excretion. So that's why, you know, in diabetes, as a symptom, we call it as they have polyuria. It's because of this increased urinary glucose, there is increased water excretion. So this polyuria will lead to dehydration. Because I'm having significant water loss in urine, I will develop dehydration. So majority of the symptoms that we get in diabetic ketoacidosis is due to dehydration. Okay. Second thing is, in diabetic ketoacidosis, this blood glucose, you're not able to see, you have insulin resistance, right? So you're not able to utilize this blood glucose by the cells. For the cells to use the glucose, you need insulin. Insulin is the one which is facilitating the entry of glucose into the cells. But these cells are not able to utilize this glucose. So instead, they switch to free fatty acids as a source of energy, because they're not able to use glucose. Because you have high blood glucose level, but you have relatively low insulin activity, because its resistance is there. So when free fatty acids are used for the metabolism, as an end product, you develop, you have these keto acids produced, like beta hydroxybutyrate and all. So you develop increased production of keto acids, and the ketoacidosis will lead to metabolic acidosis. Metabolic acidosis suppresses the metabolism of the cells further, which will complicate the whole thing. So you have two major changes happening in very high glucose state. What is that? One, high urinary glucose, polyuria and dehydration. And second, You're not able to use glucose for cellular metabolism, so you're using free fatty acids, and as a byproduct or end product of free fatty acid metabolism is you're generating a lot of keto acids. These acids accumulate in the body, creating metabolic acidosis. That's the basic of diabetic ketoacidosis. Okay. Usually for this to happen, you need to have blood glucose level of more than 250 milligrams per deciliter. So that's why if your teacher asks, when do you diagnose DKA, you should say, sir, if the glucose is more than 250, I have signs of dehydration, and then the acid-base status on the ABG shows that there is metabolic acidosis, I can consider this case as diabetic ketoacidosis, especially when urine ketones are positive. But sir asks, sir, but what if I have a patient of diabetes, he has dehydration, but when I look at his blood glucose level, it's not 250 plus, it's just 180. And when I look at his ABG also is showing some degree of metabolic acidosis. What do you suspect? So you can say, sir, if the glucose is less than 250, we will consider this as euglycemic ketosis, which is nothing but similar to DKA, but at low glucose levels, and it is usually a side effect of SGLT2 inhibitors. So what SGLT2 inhibitors are doing is, they are not improving insulin sensitivity immediately. In the long run, yes, they help you indirectly increase the insulin sensitivity by making you lose some weight. But when I'm starting it, they are immediately not going to do that. But immediately they are bringing down the blood glucose level. But still, cells are not able to utilize whatever, even the remaining glucose. So they may still choose to go ahead with free fatty acids as their main source. And because these SGLT2 inhibitors are making you excrete more glucose in urine, it is going to push you into more polyuria, and it can lead to significant dehydration. So now you get DKA-like picture with blood glucose level less than 250. That condition is what we call as euglycemic ketosis. Euglycemic ketosis. So you can write this in the notes. Euglycemic ketosis means DKA-like illness with blood glucose less than 250 milligrams per deciliter, right? That is our one of the side effects of SGLT2 inhibitors. Okay. Then next I have is GLP-1 analogs. GLP-1 analogs, glucagon-like peptide 1 analogs. Examples we can quote, and I don't think I need to educate you about the side effects. It's all there, all over on the social media. Liraglutide, the earlier version extracted from the Gila monster. Then we have semaglutide and tirzepatide. So by acting as GLP-1 analogs, they are acting as one side appetite suppressants, other side they are facilitating the insulin production and longer action of insulin. And most important thing is that they suppress the appetite and thus decrease the intake of calorie dense food. They cause significant weight loss and a good glycemic control. So they have their own advantages and they have their own disadvantages. So what are the advantages that we're talking about? They cause weight loss, and their weight loss efficacy is way more than the SGLT2 inhibitors. That's why they are now approved also as the treatment for obesity. So they cause weight loss, that is an advantage. And they are also known to reduce the cardiovascular mortality. Again, in terms of cardiovascular mortality reduction, some drugs are at par, some are superior to SGLT2 class of inhibitors. Then what are the disadvantages? Will they cause hypoglycemia alone? The answer is no. Except insulin and sulfonylureas, no other class of drugs alone causes hypoglycemia. Because even if these drugs bring down, like, okay, they are suppressed appetite so much that I'm not eating much, my blood glucose level is dropping down. In that case, the glucagon comes that facilitates the increased production of glucose from the fat, from the muscles, and that's how my blood glucose level gets normalized, and we lose weight by this mechanism only. When I don't take sufficiently, glucagon facilitates gluconeogenesis from the fat, and that's how I'm losing fat. So as long as glucagon defense is there, I don't get hypoglycemia. But when you take insulin, the insulin blunts or suppresses the glucagon production or glucagon release, and because of that I lose the defense against hypoglycemia. So if I have taken insulin, my blood glucose level is dropping. When it drops below 70, glucagon should kick in, but glucagon is already suppressed by insulin, so it can't kick in. So I don't have such strong defense against hypoglycemia. That's why insulin and the drugs which secrete insulin like sulfonylureas, they cause hypoglycemia. The drugs which do not involve insulin in their action do not cause hypoglycemia. So what are the disadvantages of this? One of the disadvantages is pancreatitis. In fact, with the recent surge of use of these drugs for weight loss, we have started seeing more number of cases of pancreatitis induced by SGLT2 inhibitors. Well, it's at a stage where the class of drugs are going through controversies, because some resources say that the incidence of pancreatitis that we get, or even the vision loss or the retinal toxicity that we are seeing in these patients, some studies have also shown increased fracture risk in some patients. Some studies have shown that they lose muscle mass and develop sarcopenia. All of these are real side effects. But then the incidence of these side effects versus the benefit that we get, as of now, the literature believes benefit definitely outweighs the risks, and in the right candidate, we should consider using GLP-1 analogs. But when it comes to GLP-1 analogs as a weight loss drugs, I have my reservations, because now the recent studies have shown that if you stop the GLP-1 analogs, like, okay, I started it, let us say one big Bollywood director comes to me saying that, sir, I am obese from my childhood, but I want to lose weight. And I just prescribe him, let us say, semaglutide. He will lose weight. He will lose 12 to 14 kgs in 3-4 months. The great reduction in the weight. He is happy. Then I stop the drug. The lost weight is usually regained within 9 to 12 months, maximum 18 months. Majority of the patients, like 80 to 90% of the patients, gain that weight loss back. If I'm prescribing it for weight loss, I should prescribe it only for those people who are, after the weight loss, are able to, mentally, physically, are capable of sustaining a good lifestyle. If they can't, then these class of drugs are only a temporary fix, and the problem will come back again. And some studies have also shown that the weight gain that happens after stopping the drug may be more than what they have lost. Like, I have lost 12 kg and I may gain 15 kg after stopping the drugs. So use it in an individual who is highly motivated and capable of sustaining a healthy lifestyle after weight loss. If not, please do not consider it. Next is insulinemia. Jessica, absolutely right. Okay. The word sarcopenia refers to muscle loss, because these GLP-1 analogs inhibit intake of food. So when I take less food, I lose fat as well as muscle. So that's why if at all I'm prescribing these class of drugs to anyone, I would insist that they should go to gym. There should be resistance training so that they can retain the muscle mass. Because one of the mechanism behind why they get more weight gain after stopping the drug is sarcopenia. Because see, let us say I am type 2 diabetic, or I am pre-diabetic, obese. You give me this drug, so I lose weight because I'm not able to eat sufficient quantities. I lose weight. But when I'm losing weight, I'm losing fat and muscle. The outcome of this is fat loss and the muscle loss. On the scale, my weight loss is good. But first of all, if you see these individuals, they look little sick, or like you can say cancer patients like appearance. That's because they've lost the muscle mass. On the other hand, someone else loses the weight by going to gym, following a healthy lifestyle and the diet. They look much better, younger, because they gain muscle or at least retain muscle and lose fat. So they look toned and better. These people look little sick like. If you might have seen a lot of people in social media looking sick like. Second thing, they've lost the muscle now. And muscle is one of the largest organ utilizing glucose after your brain. So once I have lost that, I lose insulin sensitivity significantly. I become even more insulin resistant. And that's how I tend to gain even more weight, because there will be more hyperinsulinemia, more fat formation, and I gain more weight. So that's why use these drugs very cautiously in a right person who can have a healthy lifestyle. Okay. Now coming to the next class of drugs, we have insulins. Now, insulins, we will consider them into short acting and long acting. Short acting can be further divided as ultra short acting. I will keep it simple now. Short acting insulin, you have the regular insulin, and an example that we can give for long acting, we have NPH, Detemir, and Glargine. Okay. The common insulin that some of your relatives may be taking, Act Rapid, it's a short acting insulin. It's there in the name, Act Rapid. Then you might have heard about some people taking insulin in a prefixed combination of short acting and long acting. It's like 30, 70, 50, 50. It's a combination of, like, if it is 30, 70, if they say some insulin is written as 30, 70, that means 30% is short acting and 70% of the insulin is long acting. So what are the objectives of using the short and long acting? So short acting insulin is for controlling postprandial glucose, postprandial surge in glucose, and these drugs are used for basal glucose control. We'll try to understand what does that mean. In Reed Harrison, we will do a more detailed session on how to use insulin, how to up titrate, down titrate and all. But for now, we will just get a basic clarity. You know how human body works is, if I plot a graph of an individual's blood glucose level and insulin level throughout the day. So what will happen to my blood glucose level? I got up in the morning, right? So in the night, let us say the green color is blood glucose and red color is insulin. So I got up in the morning. Okay. So let us say it is 8 a.m. I was sleeping before that. So in the night, I had my dinner at 8 p.m. So after that, my glucose would have increased, but then my cells and all are using the glucose. So my blood glucose level will be coming down. So in the night, I will have very low blood glucose level. But when I get up in the morning, I start doing physical activity. So I need more glucose in the blood. So nature has given me some mechanisms. What are those? The cortisol. So when we get up in the morning, just before we wake up, the cortisol starts rising. And you might remember, that's why if I have to check the cortisol, I have to do 8 a.m. because that is where we have a peak cortisol production. So this cortisol facilitates gluconeogenesis. So more glucose starts coming into blood. After that, I will have my breakfast, and then, so it initially increases. Initially, blood glucose level increases because of cortisol, and after that, let us say I had my breakfast, the blood glucose level will significantly increase, and then it starts coming down. Why does it start coming down? Let us say I had my breakfast and my blood glucose level jumped to, I'm just giving you an example, 180 milligrams, depending on what I had. Let us say I had this rava kesari or kesari bath with a gulab jamun, lot of sugar, lot of carb, shoots up significantly. Instead, I had an egg and some vegetables. I may not go to 180, I may go to 140. It varies. Now it has gone to 180. I don't want to keep it at that level. So what will happen? Body will start producing insulin. So overnight my insulin levels were low. But as the blood glucose level increases, to counter that, the insulin also increases. And once the insulin increases, the blood glucose level starts coming down. And if the blood glucose level starts coming down, the insulin will also start coming down. Okay. After that, let us say it's 1 p.m. and I had my lunch. So when I had my lunch, my blood glucose level will increase again. So this time, depending on the carbohydrate load, let us say I had one omelette and some vegetables. So not much of carbohydrate load. So in that case, it may not go to my previous value, maybe little less. So it keeps varying. It's normal physiology. No one should really worry about the fluctuations. No one should really worry about the insulin spike. Nowadays in social media, a lot of influencers are like, oh, this, if you eat, it causes insulin spike. If you eat that, it causes insulin spike. That's how the physiology is designed. It is resilient. Its job is, when your blood glucose level increases, insulin should increase to bring it down. So now again, insulin will increase and then it will bring the blood glucose level down. So this is how the thing progresses throughout the day. Every time you eat, glucose spikes, insulin spikes. And as the glucose starts coming down, the insulin will also start coming down. So when I look at this, you have some insulin always present in your body. And that insulin level increases after each meal. So when I'm treating you, I have to replicate this physiology. So I have to increase your insulin level after each meal, so that this meal induced hyperglycemia is countered. But at the same time, to keep your blood glucose level within the normal range between meals, I still need some amount of insulin. So this insulin spike can be recreated by short acting insulin. So just before the meal, if I give a short acting insulin, it's short acting, so it peaks quickly, so it can counter this meal induced hyperglycemia or postprandial hyperglycemia. But between the meals, to control the sugar, because the short acting will act for a short period of time and then it will come down, I need to have long acting insulin. So long acting insulin acts as your continuous insulin production, and short acting insulin counters the postprandial hyperglycemia, right? So as a rough rule, I'm again saying no hard and fast rule when it comes to insulin. It's all managed based on patient's parameters. But as a rough rule, we tend to give 2/3 of total insulin requirement as long acting, because in our body also, if I say how much insulin was released in 24 hours, out of that 2/3 was released continuously to control the blood glucose level at baseline, and then 1/3 of total insulin gets released during the meal induced hyperglycemia. So we will also try to recreate that. That's why we get this most common combination as 30-70. 30% is short acting, which will counter the meal induced hyperglycemia. 70% is long acting. Okay, we can give it in a fixed dose combination, or we can give it separately. What is the best mode? It is to give separately give long acting and separately give short acting. Okay, so this is about our management of diabetes. Now the last thing is assessment. Okay, now you started the medications and now you need to know whether the glucose is controlled or not. How do I know whether it is controlled or not? Okay, so please remember, I can assess it by looking at HbA1c or CGM. CGM stands for continuous glucose monitor. HbA1c is glycated hemoglobin. So glycated hemoglobin gives the average blood glucose or mean blood glucose level over a period of 3 months. So HbA1c calculates what we call as mean blood glucose level over a period of 3 months. And CGM continuously monitors your glucose. Okay. Now you might ask, sir, why don't we check the MBBS and PPBS, which many doctors do for assessing the glycemic control? It's not the preferred method, because your single MBBS or single PPBS is influenced by various factors. Like, okay, I need to have when we check MBBS, I need to have 8 hours of no calorie intake. But what if a patient had 14 hours of no calorie intake? MBBS will invariably come low. It has happened many times. It's like patients themselves manipulate the outcome. They know that they're not doing the diet properly, but if the MBBS comes high, the family members will start pricking them, and then they will restrict their food preferences and all. So they just want to avoid. So what they will do is, okay, tomorrow I have to check the blood glucose levels. Then today afternoon I'll reduce the calorie intake. Dinner I will altogether skip. So next day's MBBS will come 10-15% less. So that is how they manipulate. So that's why a single MBBS or single PPBS are not a very reliable way of assessing glycemic control. It can be easily manipulated. But if I check HbA1c, if you had a good lifestyle, good dietary preferences, and good adherence to medication, then only this will be coming low. If all throughout the 3 months you were messing up, but in last 2 days you followed strict diet, you can't fool the HbA1c, right? So that's why it used to be the preferred mode of assessing the glycemic control. Even today in our practice, HbA1c is the most commonly performed test to assess the glycemic control, because it is relatively cheap and trustable. Yeah, they have their own limitations, because it is glycated hemoglobin that we're checking at. So if you have high or low hemoglobin, or you have abnormal hemoglobins, it can be altered, or it can be falsely low or high. But then the HbA1c does not help me to manage the diabetes better. I'll tell you how. Because it is calculating the mean blood glucose, or in simple words, average blood glucose level over last 3 months, right? So let us take an example. Let's say I had an individual whose blood glucose levels were fluctuating between 50. So like let us say 50% of the times his blood glucose level used to be 50, and remaining 50% of the times his blood glucose level used to be 350. So in that case, what will be the average blood glucose? 50 plus 350 divided by 2, because half of the time it was 50, half of the time it was 350. So in that case, average will be 200. Okay. Let us say another individual whose blood glucose level is always 200, in that range. So his average will also be 200. So both of them will have same HbA1c. A person whose blood glucose level is constantly 200, and someone who, like in 24 hours, let us say, during daytime it used to be 350, during night it used to be 50. Just giving you a hypothetical example. Both of them have same HbA1c. But you know, this person is doing much better than this person, because this person has a high glucose variability. He's going towards hypo, that is 50, and severe hyperglycemia, that is 350. This patient is in a reasonably similar range, around 200. So though two people have same HbA1c, they don't have the same variations in the glucose. So that variation in the glucose also matters. At 350, this person is prone for developing DKA, 250 plus. And at 50, hypoglycemia is also prone to death. This person is unlikely to be prone to develop DKA, and neither hypoglycemia. So that's why HbA1c, being an average indicator, today it's not ideally a preferred investigation. So what is the preferred assessment tool? CGM is the preferred tool. So what is CGM? It stands for continuous glucose monitor. You might have seen a lot of people, cricketers, wearing some device on their skin. It continuously monitors the blood glucose level for 14 days. Near future, we will have CGMs which can monitor for a longer period. As of now, we have they monitor the glucose for 14 days. So at the end of 14 days, we will have the data of, in this last 14 days, how was your glucose behaving? When was it going low? When was it going high? What was the average glucose? High means how high, low means how low. And we have a defined target range. We want the glucose in this range. How many times it was above this range? How many times it was below this range? So we get a very clear picture of how glucose is behaving, and accordingly we can adjust. For example, someone's fasting glucose is high. So in that case, it might call for increasing the nighttime insulin, so that by morning the sugar is controlled. If someone is having blood glucose level going high after meals, but fasting is well controlled, it calls for increasing the postprandial, the insulin that we use as the pre-meal insulin. So it helps us to titrate the treatment better. So that's why it is the preferred tool right now. Because these sensors are expensive. So a single day parameter of glucose is never acceptable or never reliable. So if I create a glucose sensor which detects only for one day, the problem is today I can manipulate you, right? Okay, if I'm a patient, see, there are a lot of psychological factors that come into patient care. So it's not just the book. Every patient is different. So let us just take an example of a patient who has a family which is strictly trying to help him. Like the family wants him to have a better diabetes control, so they are restricting him from eating sweets, eating high GI food items, but he doesn't want that restriction because he still wants to eat. So in that case, what he will do, if he comes to the hospital and if his blood glucose level is found high, then the doctor will say your sugar is not controlled, you need to have more control on the diet. Then the family will become more strict, which he doesn't want. So what he will do, he will try to manipulate the sugar results. How he can manipulate? So if you're doing just one day monitoring, then that day he will be choosing the low GI food items, low calorie food items, sugar is totally avoided. Then the readings will be better, and the doctor will say the readings are better, so you can continue the same. You can continue the same dietary practices that you're following. So then again he will go back and eat whatever he wants. But if it is 14 days, how long you can rigidly manipulate? 1 day, 2 days, but eventually the other days you will get caught. So that's why to account for these behavioral variations, having a relatively longer period of monitoring is beneficial. So currently available sensors are viable for 14 days. In the future, if we get sensors which are viable for longer period, maybe we will switch to those sensors and we will have the data of longer period of glycemic control. Of course, I would prefer to know my patient's sugar on a daily basis so that I can adjust, and in fact I can train them, like, okay, if your sugar is spiking after breakfast, maybe I want you to increase your pre-breakfast short-acting insulin by 2 to 4 units. If your sugar is spiking after lunch, maybe I would like to increase the short-acting that you take pre-lunch. So I can adjust better way if I know patients' daily sugar values. In fact, when I was too busy practicing, we used to have these WhatsApp chat lines open with patients. Now we have technology and apps, and so back then patients used to keep texting me about their pre-breakfast, pre-lunch, pre-dinner values, and we used to tell them how much insulin to increase or decrease, or whether they should take the regular dose. But the CGM makes these things much more easier. I don't have to constantly keep texting the patients, and as the sensors get advanced, maybe the CGM data will be linked to the clinician or the hospital, and the hospital will also be getting notifications about what is happening to their patient's glucose levels, and accordingly they can, like, what if I get a patient, if my phone says that one of your patient is having a glucose of 600, then I know he is going to develop DK or HHS pretty soon and he needs insulin now. So I would probably instruct him to come to the hospital and take the next steps. So CGM is going to definitely advance the way diabetes is managed in near future. Okay. See, so when we are checking the fasting blood glucose level, Captain, for any person, we are accounting for the cortisol induced hyperglycemia. So when you say that the normal blood glucose level fasting is less than 110 milligrams per deciliter, that means less than 110 because of your cortisol. So cortisol spike at 8 a.m. is a norm. It will happen for everyone. If it does not happen, it will put you at the risk of death, because we need this stress defense always, because suddenly body goes into a physical or physiological stress, and during that stress body needs to burn more glucose. Like, let us say I have, like, in front of me there is a tiger, I need to run, right? I need to run, I need to put all my resources into my leg muscles. They need a lot of glucose, they'll need a lot of NAD plus, all of that is required. So suddenly how will I get an elevation in the glucose? Glucagon also comes, but cortisol is the leader apart from the adrenaline. So cortisol rises every time you have stress, and day is stressful than the night. So night you are resting, so that's why you don't have high cortisol. But once I'm about to start the day, I need a higher glucose and I should be higher prepared for stress. So cortisol spike happens. If that spike does not happen, then I can be prone to develop hypotension, shock, and death. That's what we call as hypoadrenalism. Okay, so this is about our diabetes. Now the target glycemic control. CGM, as an undergraduate student, as of now, you don't need to know all the CGM parameters. Just know that CGM is preferred. But HbA1c, we do ask you. So the target HbA1c is less than 7%. This is as per the American Diabetes Association guidelines 2025. Okay, I will give the 2026 update soon, but anyway, it's not going to change. You can aim for a relaxed glycemic control in patients who are at risk of hypoglycemia, right? Like, I want to get this HbA1c to less than 7, and to achieve that I give sulfonylureas, insulin and all, and patients repeatedly keep getting hypoglycemia. Hypoglycemic episodes are equally dangerous. So in such patients where HbA1c of less than 7 cannot be achieved easily because of the risk of hypoglycemia, in them we can relax to 8%. But otherwise, for most people, less than 7% is the target. Now you may ask, sir, is it a random number? Like, okay, someone thought that, oh, in diabetes it is more than 6.5, it can be 8, 9, 10 and all. So let me use 7 as a control. No, it is rigorously backed by scientific studies. So what studies have shown is that we have studied about all these complications of nephropathy, retinopathy, coronary vascular disease, stroke, peripheral vascular disease. All these complications, their risk correlates with the HbA1c levels, or the glycemic control in simple words. So to bring their risk down significantly, I need to have HbA1c of less than 7. So many times I have seen this, even medical students arguing with me, sir, my aunt was diabetic, she was prescribed some medication, her HbA1c was 11, now it is 9.2, so shall we continue the same medications? The answer is a big no. We have not achieved the target yet. So you may be happy it has come down from 11 odd to 9 odd. So some reduction in the complication risk, but not significant reduction. So at 9.2, she will still develop retinopathy, nephropathy, neuropathy, coronary artery disease, and her death risk will be high. She is always sitting on high death risk. So if I want to minimize all this complication and mortality risk, then I have to bring the HbA1c less than 7. Okay. So this 7 is a number that I want you to remember. You teachers do ask. Okay. So one last bit to add now, and then we will move to the next topic. That is indications. So when I'm talking about diabetes, we're also talking about pointers that will be asked in your Viva OSCE. Because in your Viva OSCE, one of the common table is where they keep the drugs and instruments. And in that drugs and instruments station, many times they keep insulins, and they will ask you to tell the uses of the insulin. And also they talk about the types. Okay, so there is Actrapid, or there is Detamir, or Glargine kept, or NPH kept, or Lispro kept, and then they will ask you, is it short acting or long acting? So you should be able to tell that. Okay. Apart from that, they will ask what are the uses. So of course, you will tell, sir, it is the drug of choice for type 1, and in type 2, if the lifestyle or other pharmacotherapy is not able to control in sugar, we can consider insulin. But they will ask you, where else do you use apart from diabetes? Where else do you use? Can anybody tell me? Where else do we use the insulin apart from diabetes? It's a very common Viva OSCE question. Very common Viva OSCE question. See, we use, because insulin not only shifts glucose from extracellular to intracellular compartment, it also facilitates shifting of potassium from extra to intracellular compartment. So we use glucose for treatment of hyperglycemia, right? So in this OSCE station, if you tell me, sir, what you gave me is Detamir, it is a long-acting insulin. It is used as a basal insulin to control the basal blood glucose level. And then I can use this for type 1 as a drug of choice along with short-acting, or I can use it in type 2 when lifestyle modifications and oral pharmacotherapy has failed. Then the sir will ask, where else do you use? Sir, we can use insulin, not this long-acting, but short-acting can be used for treatment of hyperglycemia. Then the teacher might ask, but what if the patient is non-diabetic and you give insulin for bringing down the potassium? Sugar will also come down. No, he will crash. He will have hypoglycemia. How will you counter it? So then you can say, sir, I will accompany this insulin with the glucose. So dextrose plus insulin infusion I will give. So that will make sure that hypoglycemia doesn't happen, but potassium gets shifted from extracellular to intracellular compartment. If you're answering this much, that station teacher will be very happy. But to give you some extra points, he may throw one more question. Tell me the indications for starting insulin in a diabetes patient. So indications for insulin. When do you start? So in type 1, on diagnosis. So right now I have diagnosed you as having type 1 diabetes mellitus. Immediately I have to start you on insulin because there's no other therapy available. But for type 2 diabetes mellitus, insulin is not the first drug of choice. So when do we use it? First one, T2DM uncontrolled despite oral hypoglycemic agents, OHAs, at optimal doses. Means we have tried to use them at well tolerated doses, but still patient's sugars are not controlled. When do you say it's not controlled? HbA1c is remaining more than 7 despite me trying to use multiple oral hypoglycemic agents. Second, HbA1c of more than 10%. Again, please remember, if the HbA1c is more than 10%, that does not mean that you have to continue insulin lifelong. But at this point of time, when HbA1c is more than 10%, the mean blood glucose level is generally more than 250. Such cases, even if I give oral hypoglycemic agents, I may not be able to see a dramatic drop, but this patient with such high glucose is sitting on the risk of DKA and HHS. So at least for an immediate initial control, I will start insulin. Once the glycemic control is good, maybe I can phase out insulin and switch to oral. So a lot of patients are there who are started initially on insulin, but then eventually the insulin is phased out and they are started on oral. So please remember that it's a myth if someone says that once insulin is started, lifelong they have to take insulin. Right? It depends on various other factors. Then the third indication is, see Sutapa, when we are giving insulin for treatment of hyperglycemia, hyperkalemia, I'm not talking about the diabetes. In diabetes, of course, we are giving insulin alone. Why should I give glucose? Already glucose in the blood is high. So if I have high amount of potassium in the blood, the insulin facilitates the entry of this potassium into cells. But it will also make sure that glucose also gets entered into the cell. So I will have hypoglycemia, right? As simple as that. Now I want to prevent this hypoglycemia from happening. How can I prevent? If I keep giving glucose externally, then whatever glucose that gets shifted into the cell because of insulin is counterbalanced by the externally given glucose. So that's why I'm adding dextrose. That's it. So in simple words, to prevent hypoglycemia, side effect of insulin. Jessica, true. See, especially psychiatry, in the early stages was quite inhumane. With time, psychiatry has evolved. So a lot of, see, even modern medicine that we practice today, it started with very crude forms. In the past, we used to do bloodletting. Bloodletting in the sense, there was also belief in the modern medicine practitioners before the science took over that there is something called as impure blood and pure blood. So if you cut and let them bleed, they lose impure blood, and that helps them come out of diseases. So you might have seen even now some alternate medicine practitioners follow that. They prick some vein on the scar, on the forehead, and they make them bleed. We, like the so-called English medicine or modern medicine people, also have practiced those things in the past. Yeah, but now things have evolved. We have better science. We know what works and what doesn't works from clinical trials. So today we all follow evidence-based medicine. So nobody is following insulin coma for treating the psychiatric disorders. Okay, HbA1c of more than 10% is one. Then this is very important. Okay, what I'm telling you now, because as a doctor you should know this, because you will get queries on this. Diabetes with signs and symptoms regardless of the blood glucose level or HbA1c levels. What are signs and symptoms? Polyuria, polyphagia, polydipsia. If you're getting these symptoms, that means you have severe hyperglycemia regardless of what your glucometer is showing. Such patients should be started on insulin. Again, later if things get well controlled, you can switch to oral, but at this point of time they require insulin. So many times it happens, like relatives call, Santhosh, I got a glucose checked, it is around 200, but doctor is telling I need to start insulin. But one of my colleague also had 240, but for him doctor started on tablets, but for me he's saying insulin. Should I take insulin? I have a fear of injection. I will ask them, do you have these symptoms? If he says yes, then I would tell them, your doctor is right. Right now you need insulin. Start taking insulin, fix your lifestyle, fix your diet, and hopefully doctor may be able to phase out insulin in the near future. But right now you need insulin. Okay. The next indication for insulin is hyperglycemic crisis. Means if you are in a crisis situation because of hyperglycemia, what are those? DKA and HHS. Diabetic ketoacidosis or hyperglycemic hyperosmolar state. Then of course you need insulin immediately. If not, you're going to die because of losing fluids and dehydration or fluid deficit and electrolyte imbalance, right? So these are the indications for insulin. And You can say that these parameters, symptomatic diabetes and hyperglycemic crisis, are absolute indications for initiating insulin. You have to start, you don't have other choice. Okay, so that completes our diabetes. We will go to the next chapter. Okay, I think we will have a little bit of crunch of time, so let us quickly go through the remaining topics as well. Okay, so the next thing that we are going to discuss is going to be on hyperprolactinemia. I think it will also be addressed in OBG to some extent. So a question may be asking you to list the clinical features, causes, diagnosis and management of hyperprolactinemia. Now, to understand this topic, see, HHS and DK, these are hyperglycemic crisis. So, okay, what is happening in if the blood glucose level is high and you have, coupled with that, you have low insulin. So what is happening? You will have polyuria because you are losing a lot of glucose in urine. Your blood glucose was high, so you will have high urine glucose also. And when you are losing glucose in urine, you are also losing water. So you have polyuria, which is pushing you towards dehydration or fluid deficit. DKA patients are severely dehydrated. They would have already lost, by the time they come to hospital, they would have lost 5 to 6 liters of body fluids. They would have lost significant weight, but which is just because of water loss. Second thing is because you have insulin deficiency, free fatty acids become either insulin deficiency or insulin inaction. You have free fatty acids as source of energy, and as a byproduct of this free fatty acid metabolism, you have production of keto acids, or what you call as ketone bodies. And this dehydration is the main reason for the mortality risk. But ketoacidosis also leads to significant complications. Metabolic acidosis is a myocardial suppressant. So myocardial force of contraction activity comes down. You develop hypotension. You are already dehydrated plus hypotension, profound hypotension. That hypotension can lead to decreased perfusion of the kidney and renal shutdown, and that is acute kidney injury. Right? Then ketoacidosis will lead to ketotic breathing, because once you have ketoacidosis, metabolic, respiratory system has to compensate. So to wash out the carbon dioxide, respiratory system starts working more. So you will have tachypnea, what you call as ketotic breathing. So that will happen, or acidotic breathing. And then let us say another circumstance, HHS is a more severe form of the same complication or same problem, where you have even more increase in, so usually DKA happens after 250 up to 600 milligrams of per deciliter blood glucose. But when you have even higher, so usually 600 to 900 milligrams per deciliter of blood glucose, you will have profound polyuria and severe dehydration, more severe than what I'm talking about in case of DK. So in DK, you might be having 5 to 6 liters of fluid deficit. Here you have 9 to 12 liters of fluid deficit. Okay. Then what differentiates this so-called HHS? So this is about DK that I'm talking about, and this is HHS. In HHS, you still have some amount of insulin action. Your blood glucose level is high, but insulin action is still present. And because of that, still glucose is the main source of cellular energy. We are not switching to free fatty acids. And because of that, we are not producing ketones. So there is no ketone production as of now. And these patients, because there is no ketone production, they don't develop this acidotic breathing. So they present late. So they present when their glucose level has already gone to 900. They have lost a lot more fluids to polyuria. So this is more dangerous, because little bit of insulin is still working and sufficient enough to keep glucose as the main source of energy. In DK, we have significantly low insulin action. So we have already switched to free fatty acids, and switching to free fatty acids has generated ketones. Ketones have made me have acidotic breathing, a sense of tachypnea, breath hunger, and that makes me come to the hospital a little early. But in both cases, one thing is very clear: your blood glucose level is very high. So if I give some metformin, that blood glucose level will get controlled after 3-4 weeks when the insulin resistance comes down. If I give SGLT2 inhibitors, it will take 10-15 days. I will not see immediate result, but immediately I am going to die because of losing this so much of fluid to polyuria. So I need something that acts immediately, and the only thing that can do that is insulin. So that's why immediately we need to start insulin, control the blood glucose, correct the dehydration. Here I would have lost 5-6 liters, here I would have lost 9-12 liters. That all needs to be replaced. Do that, all of it. I get stabilized, glucose is controlled, hydration is achieved, electrolyte imbalances are corrected. Then slowly you can phase out insulin and then put me back on oral if I was already on oral. If not started, you can switch to oral. Some patients, if they already have very high glucose values, we may not be able to switch, but at least at this point of time, insulin is required. Whether we can switch or not, future will tell us. This is what you should tell the patients. Captain, I will take it up. I'm just rushing ahead of battling the time. We will take out all the doubts. Okay, so next question is discuss the clinical features, causes, diagnosis and management of hyperprolactinemia. So first let us understand prolactin as a hormone. So we know that prolactin is a hormone produced by anterior pituitary. So we have something called as hypothalamo pituitary axis. Hypothalamo pituitary axis regulating the prolactin secretion. So how do we regulate that? So anterior pituitary produces prolactin. So we have this anterior pituitary which produces prolactin. Prolactin works on the prolactin receptors, helps in the mammary glands from producing milk. But now studies have also shown that prolactin have additional roles. It might have a role in modulating the immune response to stress and infection. And it's also noted that whenever we are stressed, the prolactin levels increase. Okay. Yeah. Reproductive function is the main function where it is facilitating the mammary glands to produce milk. Okay. Now, this prolactin we have to control because milk production is not an everyday requirement. There are certain phases in life where the breast has to produce milk. The remaining times, the prolactin level should not go very high. If there is stress, if there is need for immunomodulation, prolactin may increase transiently a little bit, but a persistent elevated prolactin is not required. So I need to control it. Who will control? Hypothalamus. So anterior pituitary is the one which is producing prolactin from anterior pituitary gland, and hypothalamus is the one which is controlling it. How does the hypothalamus control? Hypothalamus produces something called as dopamine, and dopamine will have a inhibitory control on the prolactin. So it is more or less like most of the other hormones. Just to give you an example, if I have to control the growth hormone production, how will I do? Hypothalamus will secrete growth hormone releasing hormone that will stimulate the anterior pituitary to produce growth hormone. And if hypothalamus wants to inhibit the growth hormone production, it can produce another, that is somatostatin. And the somatostatin will inhibit the growth hormone production. So that is how the growth hormone production is controlled by hypothalamus. So it has mainly a stimulating hormone and an inhibiting hormone. So if I have to increase, I will send the stimulating hormone. If I have to decrease, I will send the inhibiting hormone. But prolactin is not like that. So prolactin is, see, like the growth hormone you can think of as a car getting accelerated when required and braked when required. If I want more growth hormone, I have to accelerate. But if I want less, I have to put brake. But this prolactin is like the anterior pituitary gland always wants to secrete prolactin. But there is a constant brake applied by the hypothalamus in the form of dopamine. So dopamine you can think of as a brake. It's like your car is in always running mode, but you have put a brake. The moment I release the brake, the car moves. Same here. So constantly hypothalamus keeps producing dopamine, and that is suppressing the prolactin production. If I remove the dopamine, prolactin production and release happens. So it is more or less like a brake, and it is the inhibitory control. So dopamine has an inhibitory control on the prolactin production. Why are we talking about it? Because any condition where there is dopamine inhibition, like let us say I have given some dopamine blockers to someone. So in that case, what will happen? the prolactin levels will increase. So drugs can be one of the common causes for increased prolactin production. What else can be a cause for increased prolactin production? There can be a tumor in the anterior pituitary which will produce prolactin, right? Apart from that, just as I've already told you, prolactin increases whenever there is stress. So stress can also be a reason for increased prolactin production. In fact, the ideal way to assess the prolactin levels is not a single prolactin measurement, because if I take one single prolactin measurement, the moment the staff nurse or the phlebotomist takes the syringe or a needle to prick me, that stress, that fear itself shoots up my prolactin level. So you may get a result which is already having higher prolactin values than my actual prolactin levels. So that's why ideal way of assessing the prolactin is get multiple samples spread over a day. It's called as pooled prolactin value, and then pool all of it and then take the average value, so that the stressors and their influence is eliminated. Okay, so having understood this, let us begin by listing the causes for hyperprolactinemia. So the causes can be classified as physiological causes, where the high prolactin is expected. Like for example, pregnancy. In pregnancy, higher prolactin, or when you are breastfeeding, higher prolactin is physiological. Then it could be pharmacological or pathological. So what are the physiological causes you should write, you should not miss? I think all of you can remember this. That is pregnancy and breastfeeding, or it's also called nursing. Now don't think of it as a nursing profession, nursing or breastfeeding. If you have a tendency to get confused, keep it as breastfeeding itself. Okay. Pharmacology, mainly you should remember, because dopamine is an inhibitory control. It's a brake, but if brake is taken away, prolactin production goes unbroken. So dopamine blockers or dopamine antagonists. Okay. Pathological, you should remember, importantly, two conditions I want you to remember. The first one is prolactinoma, a prolactin secreting pituitary gland tumor. Okay. And the second one, which is very common, in fact, in my practice, a lot of people get these master health checkups by these corporate labs. In that, they do so many tests, without seeing whether it is there is an indication or not. Randomly they do so many tests, and sometimes they also get a prolactin done. Now I'm so against this is because, one, it is a random prolactin level. It may be influenced by the stressors that the patient is going through. Second, many of these patients who are going for master health checkup, especially female post 35, may be hypothyroid, and hypothyroidism is also known to cause hyperprolactinemia. So their high prolactin may be just because of hypothyroidism, but they keep eating my head saying that, sir, my prolactin is slightly increased. I'm worried about it. Will I get Galactorrhea? Because I googled it and it says that there will be milk production even when you're not pregnant and nursing. So I'm worried. I have to just counsel them and look at your TSH, look at your thyroid profile. We need to correct that. This will get corrected. So I want you to remember hypothyroidism as well. And you may ask me a question, sir, why hypothyroidism is going to cause hyperprolactinemia, right? So apart from dopamine is the main inhibitory hormone, but then hypothalamus also produces one more hormone called as thyrotropin releasing hormone, TRH. TRH is known to stimulate the anterior pituitary gland to produce prolactin. And if I have hypothyroidism, my T3, T4 are low. Right, in hypothyroidism, I have these low. So if I have T3, T4 low, it will lead to increased production of TRH. And that high TRH will also stimulate the pituitary gland to produce more prolactin. So if I treat this hypothyroidism and normalize the T3, T4, then the TRH production will also get normalized. And once that happens, there is no more hyperstimulation of the prolactin secreting cells, and the prolactin levels get normalized. So that is one more point I want you to remember. Okay, so now that we know we will be classifying the causes for hyperprolactinemia into physiological, pharmacological, and pathological. These are the important ones you need to list. Okay. Anyway, I'm leaving a table which has all common causes listed apart from the important ones that we have already mentioned. Physiological, as I've already told you, we have pregnancy and nursing. Apart from that, nipple stimulation. It is in fact the strongest stimulus for the prolactin levels to rise. So when the nipple gets stimulated, because nature has designed it that way, because when the baby wants to breastfeed, it stimulates the nipples, the baby's mouth stimulates the nipples, and that leads to prolactin surge. Prolactin, because I have already told you, studies have shown that stress increases, and exercise is a form of stress on the physiology. So during exercise and immediately after that for some time, your prolactin level will be high. Similarly, sleep increases the prolactin production, and seizures also. These are physiological causes. Pharmacologically, dopamine antagonists like phenothiazines, haloperidol, lot of psychiatric drugs, even methyl dopa. These are the ones I want you to remember. Then pathological, as I've already told you, we have prolactinoma, a prolactin producing tumor from the pituitary gland. This is the most common pathological cause. So if you have ruled out physiological and drugs as the cause, then the most common cause for hyperprolactinemia is a prolactin producing pituitary tumor. Okay. Then growth hormone producing tumor also sometimes produces prolactin. We'll discuss that when we talk about growth hormone later. Okay. And hypothyroidism, I have already told you. CKD and liver failure can also cause, because once a prolactin is produced, it gets broken down to tiny peptides. They get metabolized by kidney and liver. If there is kidney failure or liver failure, you have difficulty to metabolize and excrete the prolactin product. So prolactin remains in the circulation for a longer period of time, right? So these are all the common causes for hyperprolactinemia. Now, once I have high prolactin, what clinical manifestations it will lead to? Clinical features of hyperprolactinemia. Now, the clinical features are not going to be same in males and females. They are going to be different. So in females, what are the manifestations we are expecting, and in males, what are the manifestations we are expecting? In females, of course, they have a well-developed mammary gland which is already primed and it is ready to produce the breast milk, and you stimulate it with the prolactin, milk production increases and they will have increased milk production. So they will have galactorrhea, and the prolactin inhibits GnRH, so that results in amenorrhea. So you will have galactorrhea and amenorrhea. So that's why post-pregnancy, when mother is breastfeeding, prolactin levels are high, that is inhibiting the GnRH, and you have amenorrhea for a reasonable period. So that helps, like physiology's design is that there should be spacing between the two children, so that prevents another conception happening immediately post delivery of a baby. So in females, they present with galactorrhea, amenorrhea, but in males, they mainly present with because male breast is not primed to produce milk, so unlikely that they will present with galactorrhea. In very severe form, they can, but quite rare. So galactorrhea is rare. But then they present with symptoms of testosterone deficiency. Why? Because GnRH gets suppressed by hyperprolactinemia, and once the GnRH production is less, you have low LH and FSH, so you have low testosterone production. And once there is low testosterone production, we call it as hypogonadism. You can also call it as hypogonadotrophic hypogonadism, because GnRH, FSH, LH, testosterone, everything is low. And this hypogonadism results in decreased libido or decreased interest in sexual activities. It can also lead to, because you have low testosterone, relatively you might have more estrogen, so you may develop gynecomastia. And you know, testosterone is a strong stimulant for males to have physical activity, in the sense, you know, males are physically more active, more athletic compared to females. It's because of the testosterone hormone. But if you have low testosterone, you will have low urge to have physical activities, you become lazy, you're sitting quietly in a place, you don't want to move much. So it will manifest in the form of fatigue and decreased physical activity. So males mostly present with these symptoms. Now you should only tell me who is going to present See, Sutapa, HbA1c, I think I've already told you, if it is more than 7%, there is risk of organ dysfunction. But I still have oral drugs to use. If oral drugs fail to control, then I can go for insulin. Insulin is not a good drug. So in the past, we used to say the best drug to treat diabetes is insulin, but now we know that insulin is actually the worst drug to use to treat a diabetic patient. Okay. What are the best drugs? SGLT2 inhibitors, metformin, and GLP-1 analogs. Why insulin is a bad drug to use to treat diabetes? If I give insulin, how insulin is going to decrease the blood glucose level? By taking the glucose from the blood and putting it inside the cell. Okay. Now inside the cell, if the cell is not able to utilize this, like it not spend this glucose, then what it will do? Convert it into free fatty acids and store in the adipocytes. So insulin increases the lipogenesis, increases glycogenesis and lipogenesis. So I'm storing all these extra calories, and by increasing the lipogenesis, I'm gaining weight and I'm accelerating atherosclerosis. So it's not a good drug. Instead, I want those drugs which actually keep my blood glucose level low, but at the same time help me maintain my weight, maintain my atherosclerosis progression, decrease the atherosclerosis progression. That I can achieve with SGLT2 inhibitors or GLP-1 analogs. So they are the best drugs. So that's why if it is 7+, I don't want to jump to start insulin because it's not a good drug. It has its own long-term consequences. But if I'm not able to control it to less than 7, despite use of, let us say, metformin or SGLT2 inhibitors, GLP-1 analogs, I've tried my pharmacotherapy oral drugs, but still not controlled, then I go for insulin. But if it's already 10% plus, I mean, in that case, the blood glucose level is high. The risk of this patient going into DK or HHS is very high. So I need to get that control immediately. That I can't achieve with the immediate control, or quick control is not possible with your oral hypoglycemic agent. They take their own sweet time. So that's why I'm using it if it is more than 10%. But that does not mean that if I am starting insulin, if it is more than 10%, I will stick to insulin forever. Once I achieve the target HbA1c of less than 7%, if I feel that patient's lifestyle and the dietary practices are conducive enough, I may try to phase out the insulin. Okay. So now I asked you a question, who is likely to present early? Because females develop galactorrhea and amenorrhea, and these are the symptoms they don't ignore. They present early. But decrease in libido and having fatigue, there are n number of causes. A stressed male may not have an urge to have a physical intercourse. A stressed male will of course feel fatigue. So most of them will think like, okay, my work life stress itself is the reason why I'm going through all of this. They may not come to the hospital. So they present late. Male hyperprolactinemia patients present late. So if a tumor is the reason, which is the most common pathological cause, males present when tumor is quite big. On the other hand, because galactorrhea is something that a non-pregnant women will never ignore, they present early. So that's why if pituitary adenoma is a cause, then they present at a microadenoma stage, but males present at generally macroadenoma stage. Okay. So these are the clinical features due to hyperprolactinemia. Then I also want you to mention that patients may have signs and symptoms due to pituitary adenoma. Why? Because the most common pathological cause, let us write that down also. The most common pathological cause is a prolactin producing pituitary adenoma. So if I have a tumor, high prolactin it is producing, I'm getting the symptoms. If I'm female, galactorrhea, amenorrhea. If I'm male, decreased libido and fatigue. Apart from that, this tumor itself is going to give rise to some tumor related symptoms. So what are those tumor related symptoms that we are expecting, right? So to understand that, just let us look at the pituitary gland once. So this pituitary gland has a close relationship with a structure called as optic chiasm. So this is anterior pituitary, this is posterior pituitary, and here we have hypothalamus and just above that you have this so-called optic chiasm. So you know what is optic chiasm already. So now if I have a tumor here, this tumor can expand in this direction and go and compress the optic chiasm. And when this tumor compresses the optic chiasm, what do I get as a symptom? Vision loss. What kind of vision loss we're expecting? So main thing is compression of optic chiasm, and that will result in bitemporal hemianopia. Bitemporal hemianopia. So if you want, you can sketch a visual representation so that your teachers know you know things better. So you will have bitemporal hemianopia. So you will have a visual field shrinking from this side and shrinking from this side. You have hemianopia both the sides in the temporal region. Okay, so this is tumor related. Okay, now just because we're talking about the tumor, we will also know when do we call it as microadenoma, when do we call it as macro, and when do we call it as giant adenoma. The reason why I want to talk about it is, if you get a patient of hyperprolactinemia who also has bitemporal hemianopia, by default you know that the size of the pituitary tumor is more than 1 centimeter. Why? Because from the anterior pituitary to optic chiasm, the usual distance is 10 to 12 millimeter. So if a tumor is going from here to here and causing the compression, it must be at least 1 centimeter, that is 10 millimeter. Then only it will be reaching there. A tumor less than 1 centimeter we call it as microadenoma. So those patients are less likely to present with bitemporal hemianopia. They only present with signs and symptoms of hyperprolactinemia. But if I have this bitemporal hemianopia, then you know that it's most likely going to be macroadenoma. Okay, so now we know that we have the clinical features. Let us talk about how do we diagnose. So for diagnosis, if you have a suspected hyperprolactinemia, when do you suspect? Galactorrhea, amenorrhea in female, and in any patient who presents with erectile dysfunction, libido decreased, and fatigue. In males, we evaluate for prolactin as well. So that there is a standard workup for the decreased libido and ED. The most common cause for decreased libido and ED is obesity, sedentary lifestyle. After that, it is the hypogonadism due to decreased FSH, LH, or testicular dysfunction. And after that, hyperprolactinemia. So in a suspected hyperprolactinemia case, we will estimate serum prolactin. Then I want you to write here, preferably pooled prolactin. Preferably pooled prolactin. What do I mean by that? We're not taking one sample, we're taking multiple samples, pooling all of those samples and then measuring the prolactin levels in that, because stress does influence the prolactin level. So if taking one sample, patient is going through stress, his values will come higher and it can mislead our diagnosis. And once the prolactin level is, if it is normal, then we have to evaluate for other causes for patient symptoms. But if it is high, if the prolactin level is high, then you have hyperprolactinemia. Now I have to evaluate for the cause, right? And as I've already told you, you have to think about, rule out physiological causes and drugs. Then chronic liver disease and renal failure, because these are all common causes known to cause, and hypothyroidism. So that means if the prolactin level is high, I have to take the history to see if there is any physiological cause. Like, what if this person is actually breastfeeding? What if this person is pregnant, but she may not be knowing as of now? Then I should also look at her prescriptions. She might be getting some dopamine blockers. Then I should also check their TSH. Plenty of females presenting with galactorrhea, amenorrhea may have hypothyroidism, so I have to factor in that. And then I should also assess their liver and kidney functions. If all of them are normal, then these conditions are ruled out. Then the most common cause is prolactin producing pituitary adenoma. And for that, what investigation I should go for? Can a CT scan detect the prolactinoma? No, it's not a very good investigation for soft tissue tumors of the brain. So we have to go for MRI brain to identify the prolactin producing pituitary tumor. So that is how we are going to evaluate a case of hyperprolactinemia. Once we have evaluated, if the MRI brain shows no prolactinoma, then again you have to evaluate for other causes. But if the MRI brain shows prolactinoma present, so if there is an anterior pituitary tumor present, that is prolactinoma, then you go ahead with treating accordingly, right? Okay, so now let us understand how do I treat hyperprolactinemia, which is caused by other conditions, and how do I treat hyperprolactinemia due to prolactinoma. So when it comes to the management, so if I have increased prolactin, secondary to hypothyroidism, CLD, CKD, then we have to just treat underlying cause. If you treat hypothyroidism, then prolactin levels will get normalized. You don't have to prescribe any medications to them. Just treat the underlying cause. If it is drugs, you have to withdraw. But if it is prolactinoma, that is a prolactin producing tumor, how am I going to manage? We have to, okay. Now, what if it is a macroadenoma? What if it is a giant adenoma? Okay, we will write down when do we call it as micro, macro and giant, but tell me, how do I manage? Like I have a patient who has got a prolactin producing tumor and it is probably macro because he has got bitemporal hemianopia and high prolactin. Should I manage with drugs or should I go for surgery? So if the tumor is less than 1 centimeter, we call it as microprolactinoma or microadenoma. And if it is 1 to 4 centimeter, we will call it as macroadenoma. And if it is more than 4 centimeter, we will call it as giant adenoma. So the answer is because the proliferation or growth of prolactin producing cells in the anterior pituitary and secretion of prolactin both are inhibited by dopamine. So if I give dopamine agonist, they will not only inhibit prolactin secretion, they will also inhibit the replication or growth of prolactin producing cells. So studies have shown that if you give the agents to act like dopamine agonist, they will not only suppress prolactin production, they will cause the tumor shrinkage. So surgery is not required for most cases. Even when the prolactinoma is giant, even if it is 4 or 5 centimeters, you may not require surgery. All you have to do is start the dopamine agonist. Even if they have bitemporal hemianopia, you don't have to go ahead with surgery first. So start with the dopamine agonist. Only in those cases where dopamine agonist fail to shrink the tumor, then we go for the surgery. So regardless of the size, regardless of the compressive symptoms, that is bitemporal hemianopia, all prolactinomas, first line management is going to be dopamine agonists. So can anybody give me the examples for dopamine agonists that we can use? Commonly used dopamine agonists include, one is bromocriptine, the second one is cabergoline. Bromocriptine is short acting, cabergoline is
long acting. So cabergoline can be given once or twice a week dosage. Bromocriptine requires multiple dosing per day. So what would you prefer if you are a doctor treating? A short acting or cabergoline, which is relatively long acting? So Sudhap, I think I addressed this right in CLD and CKD, because once prolactin is produced, it gets metabolized. So its metabolism or its clearance includes both kidney and liver. So it has to be altered, and then the fragmented peptides and amino acids excreted by the kidney. The end products are excreted by kidney. So if I have liver dysfunction or kidney dysfunction, I may not be able to metabolize the prolactin. So prolactin remains unmetabolized in the circulation for a longer period of time. So it will act longer. So it will cause more action. So that's why it will cause hyperprolactinemia. Okay, and in the hypothyroidism, as I've already told you, if my T3, T4 are low, like let us say I had Hashimoto's thyroiditis, so there was anti-TPO antibodies and there was immune-mediated damage to the thyroid, so T3, T4 production came down. So to counter this, I will have increase. So this will lead to increase in the TSH, and to increase the TSH, actually I have to increase the thyrotropin releasing hormone or TRH coming from the hypothalamus. So if I had primary hypothyroidism, TSH and TRH will be high, and this TRH is not only going to stimulate the thyroid gland to produce more T3, T4, they also stimulate the prolactin producing cells in the pituitary to produce more prolactin. Because of this increased TRH, we have increased prolactin production and hyperprolactinemia in hypothyroidism. But if I treat hypothyroidism, T3, T4 will get normalized, then TSH and TRH will also get normalized. No more hyperstimulation of prolactinoma cells and prolactin producing cells, and you don't have hyperprolactinemia anymore. So all I have to do is just treat the underlying cause in these cases. Okay. So now most of us prefer cabergoline over bromocriptine, because being able to administer only once or twice a week is an advantage, because bromocriptine patient has to take multiple times a day. Many times they miss the dose, forget the dose. It's also not convenient to carry medications to their workplace or wherever they travel. So cabergoline is relatively more convenient, and in terms of efficacy, cabergoline is more effective than bromocriptine. Now with respect to the use of these drugs in pregnancy, I will leave it to Dr. Prasant Sir to address which one they prefer now, because in pregnancy also hyperprolactinemia because of prolactinoma can happen. So if I have to treat it, in the past we used to say that cabergoline is relatively new drug, so we don't know about its safety or teratogenicity potential. So that's why in pregnancy, though in all other cases we prefer cabergoline because of its long acting and higher efficacy, in pregnancy, at least in first trimester, we used to say bromocriptine is preferred. But over last 10 years, we have data about the safety of cabergoline. So whether the gynecologists have changed their stand and now they use cabergoline in the first trimester or not, I don't know. I leave it to Prasant Sir to address on that. Okay. So dopamine agonist can be used. Apart from dopamine agonist, we can also use somatostatin analogs. Again, somatostatin not only inhibits growth hormone, it also inhibits prolactin secretion. So we can use them also. But we consider dopamine agonist as a first line management, and we have to note here that dopamine agonists, they cause tumor shrinkage because they decrease prolactin and tumor shrinkage. So most of the prolactinomas shrink and disappear with dopamine agonists. So if tumor shrinks by more than 50%, then you just continue dopamine agonists till adequate tumor shrinkage. But if the patients fail to shrink their tumor by more than 50%, it's not shrinking at all, or it's just shrinking, like I've been giving dopamine agonist for a pretty long time, months together, but the tumor is like 10-20% reduced, like I'm doing repeated MRIs and it's not showing a sign of significant shrinkage, then such patients, you can say
we can consider it as dopamine agonist failure. So in these patients, we go for the surgical management. And what is the preferred surgical management? We go for transsphenoidal resection. So we don't have to open the skull and then go like whole skull and then get into the pituitary fossa to remove this tumor. Through the sphenoidal bone, we can just rupture the sphenoid bone and reach the anterior pituitary easily and resect the tumor from there. So transsphenoidal resection is the preferred surgical management. But when it comes to the prolactinomas, majority of them, more than 90% of the tumors shrink effectively with dopamine agonists. So that's why it is the drug of choice. It is the treatment of choice. Only those who fail dopamine agonists, in them we go for surgery. But then if I talk about, let us say, other tumors, a growth hormone producing tumor which causes acromegaly, it won't shrink with drugs easily. So there we have to go for surgery. If there is a ACTH producing tumor which causes Cushing syndrome, there drugs won't shrink it. I have to go for surgery. If there is a TSH producing tumor which causes the secondary hyperthyroidism, I have to go for surgery. But this is one tumor which is very peculiar. Drugs itself melt the tumor away, so we don't have to go for surgery in most cases. Only when dopamine agonist fail, we go for surgery. Okay, so that completes our second question. I think we might have to have another session on endocrine to cover. We have few more important questions from endocrine. One of them is acromegaly. The other one is Cushing syndrome and Conn syndrome. So if these are covered, most part of the endocrine is covered. So I'll try to have one more session according to the available slots, and I will try to address those questions as well. And tomorrow we will have rheumatology. In the rheumatology, rheumatoid arthritis, I will leave it to orthopedics to cover. And anyway, the questions are there in the Farre notes. You can refer to that. We will try to cover SLE, scleroderma, mixed connective tissue disorder. These are definitely going to be, among these three, one question is certainly going to come in your prof exam. So we'll try to address that tomorrow. So I'll sign off today, and when the next endo session is scheduled, I will let you know on my Instagram. You will be updated about it. These notes, I will make it available soon on the Telegram. You can download it from there. Okay. So that's it from me today. I'll see you in the tomorrow's class at the same time. Till then, have a good time.